January 29th, Wednesday. And today is Mental Health Advocacy Day. So we're going to have a full day of talking with our partners around the state in this realm. And we're going to start it off with Vermont Care Partners. So, thank you. Go ahead.
On the record, my name is Simone Rischmeyer. I'm Executive Director of Vermont Care Partners.
My name is Melanie Gidney. I'm the Executive Director at Clara Martin Center, and I'm President of the Vermont Care Network.
My name is Kelsey Stavsep, and I'm the Executive Director of Northeast Human Services, and I'm President of the Vermont Care Partners Council.
Thanks for joining us today.
Thanks for having us.
Thank you for having us, and thank you for taking all the testimony today for Mental Health Advocacy Day. Important day at the State House for sure. So I'd like to just start by saying, if there's anything that we talk about that you already know about, feel free to move us on or just interrupt and ask questions as we go. So Vermont Care Partners is a statewide network of 16 of the state's designated and specialized service agencies. That we are in every part of the state and designated by statute to provide services to Vermonters. I don't know how much we want to go into the details of that, but we are a vital component of Vermont's healthcare system and of the safety net for Vermonters. Last year, we served approximately 35,000 people as clients and up to about 50,000 in total. Our network should have approximately 6,000 staff. We have a vacancy rate of about 12.5%. So right now we're lower than that, but it is a large part of Vermont's economy and very important to Vermonters.
Leslie, I'm sorry.
Do you have any slides?
Yes. I believe they are listed under Simone.
Yeah.
Designated and specialized service agencies is the name of under today's date. Yes. Sorry to interrupt.
No, don't. So we just wanted to give a sense of how Vermonters enter our system of care. And there are obviously, this looks a little chaotic because there are lots of different ways that people enter and receive services. Last year, approximately 63% of our services were provided in the community. So I think that's a really big difference and important to note that it is not all office-based. We're in homes, we're in schools, and partnering and integrated with hospitals, primary care, and others.
Yeah, and just to emphasize the fact, I think we talk about ourselves as home and community-based services, which is really important. And I'll speak for NKHS, but we covered 2,000 square miles, 2 million miles last year, driving around to get the people and getting people to and from essential services. So not only are the referral pathways from our partners, specifically for us, so 25% came from our local primary care, North Country Hospital, NVRH, Brattleboro, and Probation and Parole rounded out basically our major referral sources. And so not only are we supports for Vermonters that live in the areas of the DAs and SSAs, but we're also vital supports to other institutions that feel the pressures and look to us for the expertise and refer out to us when they can't provide those services.
If I can just add in, I would speak on behalf of Clara Martin Center that we felt that accessibility is key. I think we all know that Vermonters are struggling with mental health, substance use, developmental disabilities, and having accessibility when they need it is something that we've been focused on. So we work towards a same-day access model so that people can come into our catchment area in Orange County 4 days a week and walk in and get an assessment, a full clinical assessment. So we've been able to reduce our wait list through that so that we no longer have a wait list, and then they leave with a follow-up appointment. So the goal is within 10 days, but we prefer to have it within 5. And so far our data is proving that out. And I think a shift to have right person at the right place in the right time. We've tried to shift as much clinical administrative work to support folks and just let clinicians, licensed master's level clinicians, just do the care. So that's been a system change that we've been within the past year that we've had success with. And it's really reduced the no-show rates, the high no-show rates, 30% no-show rates that we were experiencing. Just because people moved on, they got somebody else, they decided they didn't need care, and we lost that moment with them. So just accessibility, I think, for our whole network is something that we're all trying to focus on to be much more responsive and meet them where they're at when they need it.
Can I ask, has it had an effect on your vacancy rates?
Our vacancy rates are lower than they have been. So I would say, it's been a transition for staff. So staff changed staff morale because we also implemented centralized scheduling. So we could plug people right into their schedule versus going through the clinician. So they've responded really well. And I think they see the value to the clinical experience being much more positive and more responsive, and they bought into that. But there's staff morale, turnover is a very complicated puzzle. But we're stabilized post-COVID, I would say. It still remains an issue. And I think we'll talk about that down the road with the salary and benefits, the wellness of our staff, the burnout of our staff, the lack of practitioners, licensed master's level clinicians to do the therapy work has been really a challenge for us to pay a competitive rate. But in terms of the accessibility, the change in that process, I'm really proud of them and the buy-in that they've had to adapt themselves to meet clients when they walk in with not always a lot of information. So
I can add to that too. I think, when you look back at the last 3 years, I think coming out of COVID, so there's been investments, there's also been innovations in what we're doing. So some of what Melanie is referring to is same day access and some of the urgent care programs. So we do have the opportunity through new programming investments to see people the same day, to get them to a physical location if needed, if the community is not enough. And then the investments, I can speak for NKHS, but over the last 3 years, we've gone from 445 staff to 530 now. And so we've been able to recruit and retain folks. And so we've reduced our adult waiting list. There is no waiting list, and our children's waiting list from 1 year to 3 months. So, I think that's been a big case. And to Melanie's point, it's not all the paid investments, although that is what we see as the number one driver, people either staying or leaving, but also the culture and other innovative work that people are enjoying and are attracted to from a professional standpoint. So I think that speaks to the access and the referral and being that dependable partner in our communities when our partners are depending on us to take folks in that they can't serve. We've been able to do that and improve our access over the last few years.
Leslie, did you have a question?
I do. It's fantastic that you've reduced the access, wait from 1 year to 3 months, although I was struck by 3 months sounds like a long time for a person who wants to get into their, like say, losing the moment. But I understand your staffing. But if you had your way, what would you want for access? Weeks.
Same day.
Same day.
So we do
That's
have
a
that
different model. That
opportunity.
same day would be a different model, right? Or
Yeah.
Yeah.
And we do.
it's a different model. We got consultation from the National Council on Wellbeing on how to go through that process. So it is a national model that I think is getting embraced, that we've had success with. But ultimately, you want to meet with that person when they feel like they need services, they're ready for services, and that window can be really small.
Right.
So we have to be responsive and flexible to meet that need. And that's what we've embraced. I don't think everybody's there yet, but I think that's what our system of care is working towards.
But
Yeah.
if you were going to celebrate, 3 months is a celebration from 12 months, but would you have a narrower window or maybe that works?
So-
I'm just asking.
I'll clarify what I'm saying. So I think to Melanie's point, and we have other examples we can talk about through here where if you're building out the continuum, so we do have same day access. So you can be seen the same day. You're not guaranteed to see that same therapist again. And I think when you're looking for more long-term supports and services, there is a little bit of a wait time in some programs. And that varies across the state agency. So I was speaking for NKHS on those. But you can be seen same day. And we have examples of that. So our urgent care is called the front porch, but the story is saying someone looked up, where can I get mental health support on Google? They found the front porch. They came in, they were seen for a couple hours. They went home, they felt better. there is access. You can call mobile crisis. They will come out to you within an hour. So from an acute standpoint, you can be seen. From a, longer term, I want a therapist I'm going to see every month. That varies and can be harder to get into. And we see that not only with, our agencies, but any private therapist, anybody. It's just saying, look, we don't have enough space for the need that's out there currently.
So what will be the time frame between being seen acutely and then getting into a long-term relationship? Is there a gap? How does that work? Does that make sense? I'm sorry.
It
Yeah.
does. It's a valid question, and I think by agency, you might get
varies.
slight variations.
Mhm.
Because all DAs offer emergency services
Mhm.
with need to respond within an hour. If not, 6 minutes is what we can do, seconds if
No,
it's
I
via
think the
phone.
acute system is really working well.
For
Yeah.
us, it's for clinical services that you come in. We try to keep people with the same clinician. That's not always the case because it also comes down to personal choice.
Mhm.
So you may come in and we have a male clinician and they want a female, or they need a certain person with a specialty. So there's no guarantee who they come in and meet with, they'll see long-term, but we try to keep it consistent where we can, but give flexibility to meet what they're seeking.
I'm just flipping ahead on
Yeah,
the slides and I'm seeing that maybe we might address this. Any questions on this slide here?
I do.
Daisy?
So my municipality, Winooski, is very grateful for the street outreach. And I know that that's a regional program, and I know there's been some changes recently in the funding proposed for it. We're a little concerned about that because it has proven to be one of the most effective programs as far as helping folks who are either in crisis or just simply have been unable to connect with care that they really need. And these are our neighbors. I just want to remind you, there are neighbors that are really deeply in need of help. So thank you to Howard Centers who Winooski is working with. Where do those folks fall? Are those considered self-referrals or crisis supports?
I think that's more in the crisis supports, can be self-referral, but primarily in the crisis supports. And I think that what's important to note is that there's not one solution,
Yeah.
right? There's not one door, there's not one solution. When I look at this slide and I look at schools, for example, we're in over 60% of the schools. That's in a lot of ways immediate access to, right? So you're there, you're getting the supports. At other times we're in people's homes with community supports. It's not only about therapy. And I think that as a state, as a nation, if we are only focused on therapy, we're going to, there aren't enough people in the workforce for that to work. And so, yeah, street outreach is essential. Being in schools is essential. Being in emergency departments, in primary care, having mobile crisis. And it's
And I
across the
think
continuum.
street outreach is a really great example of like a model we want to replicate, but based on the funding and how that works, it's so hard to stand up models like that because the state works really hard to leverage Medicaid, which is great because that brings a lot of federal dollars that allows us to do programming. But when you look at street outreach, that's a capacity program in my mind, and saying, look, we need people who can proactively go build relationships, which I think is preventative care, and getting people in the pipeline to get the services they need so they alleviate the pressure on those more acute, and it's also our neighbors and it's just the right thing to do. But we're not funded to just stand people up to be available to go out saying, how many hits did you have? And we always talk about this as a firehouse model, but we like to make the comparison to the fire station, saying if they had to do a fee for service, you'd either be wishing for more fires so you can get paid, or you'd be cutting services. And so if we want more opportunities to be proactive, to build relationships, which is really the foundation of what we do, you can't plug and play people when you're dealing with the most vulnerable. People don't want to repeat their stories. And so the retention piece of what we do is so vital, which comes into other things we'll talk about. But I think street outreach is such a great program. It's just really hard to fund. It's really kind of saying, do we have extra funds we can pay people to do? Because a lot of the work they're doing isn't technically billable under Medicaid standards. And it just makes it so difficult to stand those programs up. We find the same thing with mobile crisis for us. Look, we're fully staffed. It's a really popular program, but we know the need is there. And sometimes you see 10 people in a day, and sometimes you don't see any people based on if they're calling, are we working closely with our partners, which we are. But if you're not getting the right amount of hits to draw down the right amount of money, you just can't have people available when you need them. It's a resource constraint. So I think street outreach is that kind of ideal. Let's go be proactive in the long-term outcomes from that. It's like, you're going to see the reduction in is anybody better off that we're really trying to go for, but the model's not set up to support that type of work, honestly. It's really
Yes,
challenging.
but on the ground, I mean, that is what I'm hearing, is that it is those relationships and the continuity of the relationships that really helps folks just get over that little hump. And then, they're well until they can get really into that 3 month later appointment or whatever, or same day. The other thing I wanted to comment on is Leslie's question around same day access and whatnot. And you were doing consultation with National Council. I'm assuming that was actually with MTM Services who
Yes.
does same day access. Was that part of your CCBHC work?
Yes.
And we'll get into that more later.
We were awarded a grant separate from CCBHC to work with them, and it was very helpful. And just to close on that, I would just say no wrong door with that street outreach worker. It could be an acute need that they connect to or connect into multiple different services. But that I think we're trying to embrace, that whoever they come in contact, that person's responsibility to do a warm handoff to the appropriate next level within that agency system of care.
Topper, did you?
I got part of my question answered. I guess I want to know one thing. If a person is in crisis, are they going to be able to be seen at that point?
Yes.
Yes.
The answer is yes.
Right.
And that's statewide, do you know?
Statewide, we have the 2-on-1 enhanced mobile crisis. So we go out and 2 people go out and make sure that that person is safe and that they are referred. And
So in Central Vermont, as an example,
yes,
if I call the number, somebody is going to deal with me.
And so you can call 988 so NKHS and NCSS runs call centers 24/7. So the, answer rate on that is quick pickup seconds. And then mobile crisis will come to you if needed. So the standard is an hour to get to you. And then there are there's a slide on this, urgent care facilities. So like if the community, we go to you and you need a physical place to go, we can take you there. And then, so that's the crisis continuum of care. And it's meant to, address those acute needs that you're talking about, which is to be responsive in the moment right away, and then send somebody to you and then go somewhere therapeutic to meet your needs if that's necessary.
And the same thing goes for if I'm in the hospital. And I'm going to use Central Vermont as an example. And Central Vermont no longer deals with it. You're going to be able to be there.
So I think that's probably a topic we can pick up in more depth, but so most of our programs, we don't do involuntary treatment. We will assess folks, we can recommend EE or involuntary treatment, work with DMH and the judiciary, but then we do need to refer out to Brattleboro or CVMC as the last resort for inpatient psychiatric treatment. So that is not something that we do, is involuntary treatment.
or inpatients.
Or inpatient.
Right, let's
Okay,
move on.
move on to the next slide. So that,
I'm sorry.
Did you have something you wanted to say?
Actually, I wanted to, if it's okay, I'd like to elaborate on your question
Okay.
about the mobile,
Is that all right, Madam Chair?
about the practice intervention.
Can you say who you are for the record?
Yes, say who you are for the record.
My name is
And
Marie Lennon. I am on the board of directors for the counseling services of Edison County. When I first came to Vermont in 2016, I was at the lowest point in my life. I went through CSAC, and unfortunately at that time, they had a waiting list for counselors. But CSAC has what they call an E-team, which is all on 24/7. Okay. You can call the E-team, somebody from the E-team will call you back and talk to you on the phone.
And that happened to you?
Yes,
Okay,
more than once,
okay.
more than once. And there were a couple of times when I ended up going to the emergency room and was in crisis.
Yeah.
And one of the team members from CSEC came to the hospital to talk to me.
So what you're doing is substantiating
Yeah.
what they say.
Thank
Okay.
you.
Thank you.
Thank you for sharing your
you.
experience. Thank you.
And let me just say, 2 years ago, I would not have been able to do this.
So this slide is a DMH slide, Vermont's Crisis Continuum Vision. And we have added in some components of where the VCP agencies are at within this. But all of this is up and running. Some of it, it's newer than other components of it. I think we've talked about some pieces of it. 988, run by NKHS and NCSS. And the mobile crisis, the enhanced mobile crisis, we'll talk more about that. And all 10 designated agencies are a part of that. And then alternatives to the emergency department. Many of those, I think it's actually extremely exciting. And over the past year and a half, 2 years, we've stood up about, how many do we have now? 6, 7 in the state, which is wonderful. And I think it was really a response to that urgent need of where do we go? And it started with PUC at United Counseling Services and focusing on kids. And now we have a number that focus on kids and a number that are adults and some that are for everybody. So working closely with DMH to figure out how to sustain those and think about how we meet the needs statewide. They've popped up because of innovation, because of funding, because of need. But again, we do want to make sure that every Vermonter has access to our urgent care centers. So this is their vision of how people enter, and really the goal is to reduce utilization in the emergency department and support people in crisis wherever they can be supported. In addition to 988, there are local crisis lines, and which we are moving more in the direction of utilizing 988 primarily, but for folks who are in the community and know that crisis line number, it's important that those still exist. We can go to the next.
The only thing I would add in here that's not on this list is that, we've also talked about the Vermont State Police embedded programming. And so, that's part of kind of a crisis response in the work. So that's not represented here, but I think is considered in the conversation when we're responding to issues in the community.
And we do have some. You want to talk about 988?
Sure. So I think just a little more in depth, folks are aware of 988. So NKHS and NCSS separate the duties. So NCSS is doing daytime during the week, and NKHS does nights and weekends. That's how we cover it. So we get to 24/7 coverage. And so the important thing that I do want to highlight about 988 is if you call, you will get somebody. And so, the hope is, and where we're headed a little bit is geotagging. So right now it's based off of area code. So if you had an 802 number and you were in California and you called it, you'd actually get us. And so I think they're trying to sort out, you want to be connected to where you are physically. And so I think they're sorting that out, but close to getting that online. But the important part is, if you don't get us, then it rolls over to our headrest partners in New Hampshire. And if you don't get headrest, it'll go national, but you will get somebody who will pick up the phone. And so you can see some of our data here. We have seen a large increase, almost, I would say, threefold over the last 3 years in need. And so I think that's one, awareness. I think the need has been there, but making sure to divert folks from 911 to 988. And on a previous slide said about 95% of all calls are resolved on the phone. So it's a great intervention. I think it diverts folks to a better level of care. And then obviously they're calling from somewhere where they're safe and it's most often resolved. And then the rest of the continuum partners nicely with this if we do need to send somebody out. But the 988 program has been a great partnership across the DAs and with DMH, and I think to great success.
I'm sorry, Brian, I see you over there, yes.
Yeah, I'm saying, I didn't want to interrupt the table because I have to leave in a little bit to go to this panel.
Okay. Do you have a question?
Yes. when I just, it's not a super important question, but when someone calls 988, what happens in between 988 and like when I'm working at First Call, the phone rings there? Because like, I'm often curious what the experience of the person is. Like, does it go right? Does some computer patch it right to the local phone, or is there a person like unplugs something and plugs it in here? Like, no, I'm kidding. How does that, what's the process? Because I'm just asking to understand. I said it's not that important because it's not like life or death right now, but when someone's like trying to call, what is their experience like? You know, that's really what I'm getting at, like in terms of waiting for someone to actually, because I know when you call our crisis line directly, sometimes it goes to the pager and then they page us and then there's this delay. And so if you could just speak a little bit about the chain of communication from dialing 988 to talking to a person.
Yeah, and so you can see here, so right here, the average speed to answer, was originally 25 seconds when we started in 2021, now it's down to 6 seconds, so someone's gonna pick up. And so I know we have our own call center, it's dedicated, it's not someone doing multiple positions. I know NCSS is moving in that direction. And we've also implemented technology. So it's hard, if 8 people call all at once, we don't have 8 people on, and that's when you roll. And so it can take longer, so it might be 45 seconds. But going back to just like, you will get a person on the phone. It's not going to go to a pager. Someone's not going to call you back. Like, you may have to wait longer if it's a high volume time. One other thing we've implemented with technology is the ability, if we are seeing high volume or if someone's out, that we have the technology to tap somebody who's on call to work anywhere. So they can work from home as long as they have internet connection. So that has helped to increase our answer rate. And so for a few months there, we were at 100%, but just based on when people call, you might get a couple that roll over. And so you're not always going to hit 100%. But the point of 988 is you're always going to get a live person fairly quickly. And for us, it's very quickly.
Does a computer do that, like the rolling over process?
I'm not sure like the technical behind the scenes, but I just want to say it's a phone. I don't know. That's like,
Probably something over.
yeah, I think there's like some way to process it. Like if it rings a bunch of times, but there's a cutoff where I'll get rolled to something else and then pick that up. So I think that is digitized. Yes. Yeah. Oh yeah. Sorry. I get what you're saying. No one's like, oh wait, headrest, New Hampshire, like that one, like the call center. No. You're right. That's the back end digital. Thank you for clarifying that.
Just speak to your question a little bit on our emergency line. We are trying to do better of making sure we have a live person to person handoff, and that's not taking messages. And not everybody, I'm not speaking for the whole network, but I know through Mobile Crisis, we are trying to make sure that people don't get lost in those cracks and that you keep the person on the phone until you have that live person that you can pass them, and that handoff is done much more with intention to make sure somebody doesn't fall through the cracks and we can't reach them again.
That's kind of what I was getting
Yeah.
at. It's like with 911, you will wait on the phone with them and then they put you through to the next person. But sometimes people call the crisis service and they get a pager and then somebody answers, but they're like answering service, and then you wait and like that 15 minutes, like we try to answer those calls quickly, but I worry sometimes what happens to people who you call them back and they don't ever call you.
Right.
You know?
Sure. I don't want to say that's guaranteed, but we're moving in that direction to eliminate that gap.
This is just curiosity on my part. We've got 3 years of data now. Are we tracking like times, days, months, like where call volume, like our
Yeah, we have
holidays especially, or?
we have we'd be happy to come back and do that detail, but there is so much data. It's actually a really good example of like how we want to kind of approach other services, but we can slice and dice the data pretty intensely to saying like, these are when a majority of the calls come in. So we can certainly come back and speak to that. We'd love to. And the last thing I wanted to do to Brian's point is saying, as an example of the importance, I think, of having a local system of care that is statewide, is that we did receive a call with someone, and so they don't have to say their name, where they are. And so we did have someone who called and was actively suicidal and gave just enough information. And because it was a DA, we were able to call the local DA somewhere else, and they were able to go do a wellness check and intervene and save this person's life, who said, I just taken a bunch of pills and I'm going to kill myself. And So that connection between the designated agencies was essential to saving that person's life. And so having 988 be local and answered by folks who are connected to other people is a pretty essential part of the crisis continuum.
Thanks. Woody, did you?
Yes, I was just continuing with your question. I'd be interested in knowing the amount of time spent on the telephone with these individuals, and also what's the age group for these phone calls?
Yeah,
I'm
we can
sure
break
there's a
that
wide
down for
range.
sure. Yep.
Thanks.
Writing down the questions so we can get back to you. So we talked about the mental health urgent care programs a little bit before. This data is from 2024, and we are closer to about 500 people across the state at this point in time. And so as you can see, counseling services, Addison County, United Counseling Services, Healthcare, HCRS, Washington County Mental Health Services, Northeast Kingdom, Howard Center, and Lamoille all have programs. We are working with BOZ as well to cross-map our data to determine the impact on emergency departments. So we're getting some of that initial data currently, and had a bit of a setback with the flood and BOZ's system, but we're backing up and running. So we will get that information to you as well. But that's been really helpful just to see what the impact is of these programs on ED utilization. Not that that's the only metric. Obviously, the most important thing is, are people better off? But we are doing that as well.
Actually, do we have data yet available on like people entering the system of care? As far as people who are visiting urgent care programs, do they have sort of pre-existing relationships with the designated agencies or in the continuum of care, or are they sort of possibly new people who are feeling like safer
Yeah.
with, a different model of receiving emergent care? I'd be
Yeah.
curious about that.
That's a good question. We don't have the numbers right now, but I would say that it's definitely both. And I know that Washington County, speak to NKHS, but Washington County and Howard Center, a lot of the folks who are going to their urgent care models are are not current clients. And then it's really a matter of what their need is and whether they need that follow-up care as to whether or not they get enrolled in programs.
And I can speak to NKHS, but yeah, over 50% are not associated with the organization.
Okay. Just wondering if we're reaching people where they.
Yeah.
I think we are.
And it's part of, it is also part of the challenge of sustainability, because if they're not clients, we can't bill Medicaid. So. That's part of it.
And I would say, one of the nice things over the last few years is the continuum being built out. And so again, as we see 998, I think there's good research that says it takes about 2 years to build models to fidelity. And so we have seen, as we trended, like an increase in utilization every month, essentially, and it's trending upward. But just like with mobile crisis, which started a year ago, we need that time. One is behavior change. I'm still seeing people. The great thing about 911 in the hospitals, like you go there, you get seen, you call 911, someone comes. And so diverting folks, making sure it just takes time to build that up. And so we are seeing increased utilization over time at these programs.
And I'm not sure it needs to be said what a much more therapeutic, better environment this is, especially for our youth, to be treated in these programs than be in an ER with all the stimulation and just not right place, right time. So that's been huge.
A lot of focus on de-escalation for sure. Talk about enhanced mobile crisis a little bit. So these numbers, actually, I just gave HCRS a call this morning to see if we had updated numbers, because these are from first 6 months. But so as of now, 2,837 people have been seen through the mobile crisis program, with 1,531 follow-ups, which is a significant increase, even as you can see from our first 6 months of data. So again, to Kelsey's point, it takes a while to build programs and for people to feel comfortable calling and to change the attitude of, I'm just gonna go to the emergency department because I know I can be seen there, right? So, but we are really trying to meet people where they're at in the community and provide the supports that they need.
Just a couple questions. This is a relatively new program, the embedded clinicians with the state police. So we're in all the state police barracks now. So they're employed by the designated agencies. They're paid through the designated agencies. It's coming out of the DMH budget or DPS.
Both.
And they're embedded. Are they available for other services if they're not being utilized? Because they're within the designated agencies, are they strictly only available? So if they're in the barracks, are they only available for that time or anything that, you know, perhaps the state police would need them for?
So,
Or
yeah, I can speak to that for our folks. So we've, so there was an expansion last year, so we went from 2 because we cover St. John's Marine Newport, so we had 2 people and now we have 4. We've also found that these positions are really enticing folks. Like when we put out applications, we get 15, 20, 30 people apply, which is like not typical of every position to put out. And when we talk to our partners at BSP, specifically, Lieutenant Nguyen in St. John's Marine, you know, said this is like one of the best things that's happened to their barracks. And so I think if I'm going to paraphrase some of the things that they do appreciate is, one, when they get a call, they respond immediately. We've had recent conversations. St. John's Marine has just been selected to be the next round for public safety enhancement team, and some of EMS and local PD are saying, look, we love the program, but with an hour response time based on your catchment area, like sometimes it's just too long. And so like we need someone there to relieve us because this isn't a criminal issue. It's not a medical issue. It's more of a social issue, and saying like there's this tension in timing. And so I think the embedded BSP program is meant to be able to respond with them, but they can also respond without them. They can do work and follow-ups from the barracks, but connected to work that BSP is doing. And so we found it's alleviating a lot of the social service aspect that police get roped into because they know call 911 and they're getting responded to calls that saying, this isn't really criminal, someone needs help, we are here. And knowing that the staffing crisis is urgent, especially in our area with BSP, they feel the alleviation of some of the calls that aren't related to the criminal aspects that they really do need to prioritize. So to your question, yes, people will work on things without the police, but they are really focused on connecting to calls that come into the barracks and alleviating some of the adjacent work that police are called to.
I think one of the things that I'm confused about this program is how it either plays with or intersects with mobile crisis units. I mean, isn't that sort of the intention of the mobile crisis units? And are these competing, or do they play well with each other?
Yeah, it's a good question. I don't see them as competing. I see them more as, again, sort of that any door, to Melanie's point before, that we can meet people where they're at. And sometimes that is with law enforcement, sometimes it's not. We try with the enhanced mobile crisis to not be going out with law enforcement. And so there's, I think they play off of each other, and different people come through different avenues and different doors. We also, I mean, we've talked a bit too about whether they could, you know, if they're not busy at the barracks, could they then go out to a call? But the funding mechanisms, the funding streams are different. And so we can't sort of swap people in the same way that we'd like to, going back to Kelsey's point about a firehouse model that we don't have. So it's really about, some of it is the constraints of the funding streams.
So these positions are not billable.
They're paid out of the grant. It's a much simpler
Yes.
drawdown for just like if you work to get paid.
Right.
And so it is a really nice thing. We do collect data. We have a good amount of data we can present on, but it is different than the mobile crisis where you're getting insurance data and making sure you're billing down. The only way you get paid is if you do it. So mobile crisis looks a little more fee for service rather than the VSP model, which is just you get paid if you have an employee there, which is great.
Which means we can't draw down federal funds.
Exactly. And
Okay,
that's always the flex and the challenge, which is like you want to draw down more funds, but if you don't get the hits, you don't get the money. And then, I will say that that creates strain on the system and saying like, this is how many people we actually need to employ to be responsive within the hour or to, a lot of the frustrations people have is like, can you come quicker? We need you now. And saying, well, if we have 2 people to cover 2,000 square miles, what's a realistic response time in the Northeast Kingdom? If you were just called away to Canaan and you need to go to Hardwick, that's a 2-hour drive. And so it is the tension between the firehouse and the fee for service model, which makes it challenging.
thank you. Oh, I think.
Can I add an example? My name is Eric. I'm the Director of Mental Health and Substance Use Services with Vermont Care Partners. I used to work in a residential program, and I have an example of a pretty intense crisis that we had where we called mobile crisis. It turned out we still needed a police and EMT response, and the individual was really, we were all struggling in the moment. It was pretty hectic. And so the police were able to respond with the embedded social worker. And that social worker played a really pivotal role in helping the individual calm down and explaining to them what was going to happen moving forward because they were going to need to go to the hospital. And they were able to come in and offer a complimentary service. They were able to start fresh and develop a new rapport with the individual, whereas the mobile crisis, since I had been working with them for about an hour at that point. And sometimes just a fresh face is really helpful. And sometimes having the authority of coming with the police is also a really nice alternative. And in other instances, having someone with the police who's not an authority figure is also a nice alternative. So I see it as really complementary.
Are the embedded clinicians with local police, are they also grant funded or are they are they able to bill for their services?
I believe those are grant funded too, right? Yeah.
Okay, I'm sorry, Daisy.
How do the pay rates of the embedded clinicians compare with those of your clinicians who are providing services under the roof of one of your regular facilities?
So the embedded positions aren't necessarily licensed clinicians. They don't need to be. So they're called mental health crisis specialists. And so that is not a required master's license eligible position. And so that can fit into a different pay band. I think we try to make those fairly competitive. And so I think that they are. I think they're paid less than the licensed clinical folks that we would have for mobile crisis. You would need at least a rostered clinician for that. So there is a slight tiered to the pay, but it's still competitive enough, at least for us to fulfill that.
I'm just trying to figure out why those positions are receiving such a high volume of applicants.
So I'll speak for NKHS, that's for us. And so it might be demographic. I know some other folks haven't had as much success as we had as hiring those, but it does help when you can have a bachelor's and you're not required to have a licensure to do that. There is robust training, but it is slightly different requirements, which does open the applicant pool. As opposed to looking for clinicians who are master level and or licensed, just really narrows the people. And also, I think the market rates for licensed clinical people is also something that weighs on the designated agency's ability to pay. And what you can get for private primary care hospitals like we are left at a detriment when recruiting for those specialized therapeutic positions.
So what is the type of training that one has to go through to be embedded with the state police?
And so again, happy to come back and speak in depth, but it is robust. And so that's a collaboration, and I don't have all the trainings offhand, but it is intentionally in a lot of different dynamic situations, sometimes wearing a bulletproof vest. So there are things that you need to be aware of. And so, but happy to come back and speak in depth about it.
Thank you.
Yep. I was talking to her because he's controlling back there.
We're gonna have 2 different slides here.
Yeah. Yeah, so I mean, I think as you all know, the designated agencies are required to provide certain services through statute. Community rehabilitation treatment services for adults with serious mental illness, children, youth and family services, 24/7 emergency services, and the DS waiver services. If you want to just go to the next slide, we try to, these are examples, it gets small, there's a lot. But the purpose of this slide is really to talk through how so many of the services that we do support those populations that we are mandated to serve through statute. And so we bucketed it into upstream supports for prevention and stabilization, holistic supports, effective intervention, and then community crisis response. We've talked quite a bit about community crisis response, and I think that's in large part because we know that a lot of folks are in crisis right now, and we have been, as a state, investing in that, and that is essential. I think all of us would probably agree that if we're going to change the trajectory 5 to 10 years out, we also have to invest in the upstream supports and the prevention and early intervention. So these are examples of some of the work we do around housing, employment services, food assistance, the community-based services from perinatal across the age continuum. We have an increase of peer supports throughout our programs that will be increasing even more with CCBHC as we implement that. We have the school-based services that we talked about, elder care. So it's robust, it's diverse, but all of these programs and supports are really necessary to care for the folks who we are mandated to support through statute.
Are we going to talk about school-based services ahead because I do have a question since you brought it up, but
we can talk about that. Let's talk about that now, because I don't think it's separate.
Really, my question was just, are we seeing a bounce back of Success Beyond 6 from where we got down to? Because of course, this is really important for education funding.
I just speak about it ourselves. Just at Clara Martin Center, we are at our highest level of clinicians in the schools. And clinicians being, we have behavioral interventionists, we have BCBAs, behavior specialists, and then master's level clinicians doing therapy in the schools. And we have branched out, we had 1 or 2 supervisory units. We're a small rural catchment area, but we're tapped into each district now. And the demand is increasing that I'm beyond, approaching what DMH's limit is that I can have. So whether the need is there, the schools, I also think we've done a better job at relationship building and meeting the school's needs and being flexible where we can. But yes, we have just exponential in the past 2 years that I've just hired another cohort of a BCBA, a supervisor, and a sub. So it's.
I think you gave a number at the beginning of your presentation that, what percentage was it that?
It's over 60%. I can double check if it's
60%
62 or 63, but I can
providing.
provide exact number. I think it really varies around the state as to whether contracts are increasing or decreasing. And a lot of that has to do with our ability to have the workforce necessary to meet the contract and relationships with schools. And I would also say that there's sort of this, a lot of it's also maybe about education, right? So if you're in a school and you're saying, I just want control over this person, I want them in the school when I need them, wherever they are, versus thinking a bit more broadly about it, to think about how if you're contracting with a designated agency, you're really benefiting from all the services that they provide. It's not just that one person in the school. And so I think there's more education to be done there, and also about the funding mechanism. And I'm not the person to talk about that, but we do have people in the room who can. But it's also about the funding mechanism, because I do believe that it does really save our system dollars, and it saves the state dollars and taxpayers as well. So,
To Laurel, I think Laurel's coming
Yeah,
in
she is.
today, so.
yeah,
And the only thing I would add, just to echo what Melanie said, we are seeing an increase in requests and what we saw come through in our area with some schools was ESSER funds through COVID, and those are ending. And so they're saying, how do we afford to keep these people? What can we do? Can we work with you? And so we have had more outreach to saying, can we have that? And, tied to these upstream supports and holistic supports, I do want to add some of the visioning that we're trying to talk about, which is like, yes, kids are struggling in school, and so that tends to draw our focus. But when you zoom out a little bit, which is what we're trying to do, it's a family systems support. We're seeing social determinants of health. And really what we're trying to do is saying, look, it's really hard, and we see this with PCPs, we see this with private therapists. They're saying, I do this one targeted specialty thing. I'm a therapist in a school for 9.5 months, but in the summer, go to the DA. The private therapists in the community turn off their phones and say, call the DA after 5 because I'm not available. And so we are the backup. And so we get stuck into these webs of other people's services. And what we're really trying to say, and especially with schools, like, I think we need a little bit more of a holistic approach. And that's some of our pitch, saying like, we need to do family system work. We need to be 12 months out of the year and to really effectively address some of the acute issues that we're seeing, especially in schools.
I would say what's unique for us too is we've actually been able to fill those contracts. So we might have had the interest before, but not the ability to fill them. So I'm not confident it's going to sustain, but for this period of time, we've been able to fill a much higher percent of those open positions.
And if we're talking about the funding, Success Beyond 6 is like one of our only non-capitated funding sources. And so it gives us more flexibility to contract directly with schools and leverage the Medicaid drawdown. Yes, we're overall capped by the state saying, hey, if you're going to have this many positions, like this is the allocation of dollars, but there's more flexibility in some ways with the funding than with our adult and children's case rates that is capped, and really puts that downward pressure on recruitment abilities with staffing and how we're able to pay or not market rates.
Heidi, did you want
Yeah, I just wanted to put.
Just say who you are.
Say for the record.
I'm sorry, Heidi Hall, I am the CFO for Washington County Mental Health. And I just wanted to kind of put out that I'm excited for Claire Martin Center and your increase in your contracts. That is not the situation in Washington County, and I don't believe it's in Chittenden County either. So we are actually experiencing we have about 30 unfilled referrals that we're waiting for. We are having extreme staffing crisis in that particular area. So so our experience is not the same at all.
For school-based.
For school.
School-based.
We are in every area, every superintendent. We are not, it's not even close.
Okay. Pepper?
You have extra people that have applied for your jobs?
In schools or in other positions? Not schools. I mean, we're doing better than we have in the past recruiting. We still have a couple openings, not to the extent of other designated agencies, but I would say on comparison, have been smaller historically, and some of the changes that have been happening in our area has led to more referrals, which we have been doing a better job of filling, but we don't have a giant surplus of folks who are applying to the school-based positions.
Not any?
Yes. Yep.
Maybe what you want to do is,
Not enough to share. I think we're just, and we have tried to do that in recruiting, saying, look, the good part about designated agencies is like, yes, we have programs, but I had mentioned we had a surplus in the VSP or mobile crisis applications. We have been saying, look, if someone feels like they have transferable skills, we should be passing those folks along. So we are trying to say, hey, we have a lot of people applying for one specific position, but would they be good somewhere else? And so if that's the case, we will share based on geography, if it's close to another adjoining designated agency, but mostly internally saying, hey, I think you might be good for this position too. Absolutely.
Do the designated agencies work together to align their pay scales?
I don't think so. You might run into some legal issues there with like some, you might be in trouble with some like wage fixing and stuff like that, and possibly collusion if you're talking about that. It cuts across kind of the competitive environment. We do use, I think a lot of people have done market studies. And so I would say that our competition is less between designated agencies because we're based in catchment areas, and who we're really competing against would be like primary care and hospitals and
Yeah.
private therapists, obviously.
That was the
Yeah.
gist of my question is at a certain point, aren't you just competing with each other for a limited number of people? And are they just moving from one to the next based upon, you know, pay rates?
I don't find a lot of like switching in between designated agencies.
Okay.
Some, but usually I can think of a few just kind of anecdotal examples, but usually that's more based on like life circumstance than saying you pay so much more. I think you would find that it's probably close-ish. I mean, you can find Indeed postings and look it up and saying, hey, how you doing? But there's no formal conversation about wage setting. But I don't see a lot of like transfer between designated agencies, at least from our shop.
And if I can just clarify with the schools, because Heidi, I don't disagree with you. Behavioral interventionists, we've been able to hire, it's bachelor's level. If I'm looking for a BCBA, I mean, there's just not enough in the state. So this is a new position for me. I should probably clarify that. I just, up until this point, had been successful at filling more than I have historically. So I'm really happy about that. But there are certain positions that are extremely difficult.
All right, let's move on a little bit. I think we're running low. Well, we're not right. We have a half an hour still. But I know that you have an amazing amount of information to
We do have
talk about.
more to talk about. So can kind of whip through some of this. We did want to just a little bit talk about the strengths, and actually to your point about whether we share information, I did want to just touch upon how the agencies really work extremely robustly together. And I'll just take a second to talk about that. The workforce, first of all, the committed and dedicated staff at the agencies is really remarkable. And we have, through the Vermont Care Partners Network, we have over 30 different working groups where staff from those agencies all come together and really work through, talk about best practice, talk about some of the challenges, meet with state folks and other stakeholders who are coming in, talk about policy, the impact, how we can improve. So that's really important. And getting to the financial piece, the CFOs actually meet weekly at this point because there's so much change going on. So there's a lot of collaborative sharing of information. Also enhanced training opportunities. We are working a lot on the mobile crisis trainings, and we have a VCP Leadership Academy now where we're trying to really think about the out years and growth in our leaders throughout the network. And we serve as a training ground. I think it's really important to note that there's so many people who come in and do their internships, get their start at the designated and specialized service agencies, and some stay and some leave. We're actually working, we will be working even more closely with colleges and universities to make that a much more formalized internship program. So that's exciting. And then the depth and breadth of programming we talked about quite a bit already, and our focus on quality and quality assurance, quality improvement, and data. That is a increasing focus of ours over the years. So, and then just quickly, the shared services. We are having a lot of conversations about doing even more of this, but right now we do quite a lot together. The agencies do quite a lot together. Some agencies share in IT services, some agencies share in staff. We have the Vermont Care Partners data repository, our unified electronic medical record, financial services, some folks share. So there's really quite a lot. And then also in terms of coverage of schools or coverage of for crisis, agencies do support one another in that as well. And then lastly, community education and involvement. There's a lot there that we do. Mental health first aid. We currently have 3 different mental health first aid grants. 3 focusing on schools, but also our SAMHSA grant, we'll see what happens with that, is also allows us to do adult mental health first aid trainings. And that is a very robust program, but there's also mental health CPR and others that across the state. Okay, I whipped through strengths. I'm trying to go quickly so that we can get to some of the other components. Did you want to talk about challenges?
Sure. I mean, I think we've touched on a lot of it. One thing I will say when I kind of think about I would say that going to one of our strengths, that we are experts in mental health and substance use. We do recruit folks with like deep knowledge. And the folks that we can keep have long institutional histories and great trainings related to more long-term care. So serious mental illness and severe emotional disturbance, we're talking about kids. We do take on the most acute. And so that creates, some of the, was talking about acute care, the crisis, the burnout, like the most intense, and we do get that a lot. And so some of our challenges, I would say, come back to retention, recruitment, keeping folks to do this hard work. When I think about it, I think we're like a specialty service. That's how we're looked at it. And usually when you get referred out to a cardiologist, that costs a lot more. It's the opposite. We're paid like generalists, expected to be specialists. And when you can make more money and do less intense work at the FQHCs or the hospitals or in private care, why wouldn't you go do that? And to Simone's point, we are a training ground. We're really proud of it. We license people and then they say, I got my license, thanks. I'm going to go do something else. Not all the time. We try to incentivize people to stay, and those who do are great. But it puts a lot of pressure on our ability to follow through on what we're supposed to be doing. We have seen an increase in referrals, I think, across the state. And so you can see the crisis continuum, the need for that is higher, which means that the follow-up and aftercare and more long-term supports is also increasing. And then I would say just, going back to the acuity, we talk about, there's some data saying, CRT is down, adult outpatient is up in terms of that. But I would say that the acuity overall is going up, and that has more to do with eligibility standards than anything else, and saying like the people we are serving have more intense needs. And then I think the kind of like social determinant adjacent issues that we're facing is saying, yes, there's underlying mental health or substance use issues, but if you're not housed, if you don't have a physical place to go, it makes it very challenging to have positive outcomes with folks. And then saying housing, how fast can we build housing, affordable housing? I think folks that we pay and have done a good job of increasing their pay still struggle. And it does feel agonizing and really frustrating to know that people who are providing supports to our most vulnerable are also vulnerable people in Vermont who, we had a legislative panel and saying, I have to go to the food shelf as a single parent to feed my kids, and I work at a social service agency. So I think that is challenging when we ask people to do that hard work and they're struggling themselves.
Are there any efforts at this point in time to deal with the situation where their services are not reimbursable by the insurance companies?
Yes, I would say, with DMH now, there's trying to bring private insurers to the table. Is an ongoing challenge. I think a lot of, our mandate has us serving underinsured or not insured folks and a lot of Medicaid, which allows us to draw that down. We can see private payers. I don't know if you want to speak to that. I think your payer mix is a little more.
I was just going to add on. As a topper, we have our payer mix is about 50-50, 50% Medicaid, 50% Medicare and third-party insurance, which is a significant change for our rural area. It used to be 75, 80% Medicaid. So we don't fully understand that shift of where those Medicaid folks are or what's happened in that regard. But in terms of the Medicare, we know that we have an aging population. We know that our older adults have significant mental health substance use needs. They're isolated at home. Getting them connected to community supports is essential, but Medicare does not cover that. And Medicare will only be reimbursed by a licensed clinical mental health counselor or an LICSW. So Medicare doesn't even reimburse a licensed alcohol drug counselor to do substance use work. So that's a federal level that we're advocating for that change because it is significant and it's only going to get more significant with our aging population. We've been lucky to have some grants prior to CCBHC, but with our CCBHC grant, our focus was on older Vermonters. And we've just hit barrier after barrier because they don't necessarily just need therapy, which is what Medicare covers. They really need those community supports and connections. And so that's been frustrating for us. In terms of third party, kind of the same situation. So increase in Blue Cross Blue Shield, Cigna, and, you know, they pay for therapy, they pay for psychiatric services, but not our full continuum of care that is really successful at supporting people. So case management services, supports in the community, peer work. We do have individual contracts with Blue Cross that I think we're all trying to negotiate and have discussions to get a broader, but it just increases the cost of healthcare. And we know the challenge is there, but it is a significant barrier to treat all payers the same and offer the same services. So significant barrier for us that we've been trying to work through, trying to find some routes to provide that continuum of care that we know is essential. Transition age youth was our other end that we also were trying to address, like with our older Vermonters, but just hit into roadblocks. Medicaid's wonderful. You know, it covers our full continuum for the most part, and the flexibility to meet them at that person-centered level of what they're looking for and what's most helpful.
So third party and Medicare are the problem.
From my perspective, yes. And the reimbursement rates vary.
And one thing I would just add that fits in kind of the strength and the challenges. So we laid out our core services. There is talk with that. The MAHHS says, you know, focus on your core services. And at the same time, they say, do this thing, do flood recovery and CCP, go to the homeless shelters, go to the hotels. We need you to be responsible for this. Do the crisis continuum. And so there are two tensions saying like, focus on your scope and then expand your scope, and saying it is one of the best things about the DAs. We're flexible. We can be responsive. We're very creative. We go out into the community, which not a lot of other folks do. And so it gives us a lot of ability to meet people where they are, right place, right time, in a therapeutic way with our expertise, but also strains us under the funding system when they're saying the DA will do it. And there is an expectation and narrative in our community saying like, why isn't the DA doing more? I think it's really harmful to us actually. And, you know, one thing we try to talk about is like, when things go wrong, we always want to talk about, you know, why and who's supposed to be doing what, and it does become nuanced. But you know, one request for this place and anybody is saying like, we do a lot of good work and need help sharing that information too, and saying like the investments over the years have increased our access, our outcomes, and saying like we do good work when we're asked to do it. And there's also a lot of work to be done and a lot of struggling folks who there's just more to serve than we can possibly do.
Excuse me.
Yes,
Before going to that slide, can you go back to the?
there was a lot on that.
Yeah. There's a lot.
I know that the paperwork is a major problem. And I also know that it's being worked on. So can you just tell us where you are with that? Because I know people that have left their job because of that.
That is absolutely true. People have left their job because of the administrative burden.
Yeah.
You know, I think we continue to work with the state on streamlining as much as we can, and to work on our IT systems in-house to, you know, automate as much as we can. And yet there are more and more demands, both from the federal and state government, just about people want to know what, you know, they want to know the information, and we have to be responsible to taxpayers and taxpayer dollars. So we completely understand that it still needs to be reined in. You know, and I think also on the education front, there needs to be a lot more work around. If you're going into this field, you actually are going to also have to be collecting information and documenting, because that is part of the job.
I think that Melanie had mentioned something at the top of your presentation of shifting some of the paperwork towards more of the administrative staff and away from, and freeing up the clinical staff to be able to provide clinical services. Is that something that's being done across all the designated agencies? Is it just Clara Martin?
I would say,
You can start. Go ahead.
I feel like we're doing it at many different levels. I think DMH and DSU is working together to look at all of their requirements from the federal and state level. We're looking at it across the board within the DA system. Many of us share EHRs, and how can we streamline that information?
I don't want to interrupt. Go ahead.
So there's that work as the broad VCP network and then cohorts within VCP. And then it's an absolute constant within each of our organizations around how do we manage this? Because the experience isn't just on the clinician, and it is still after pay, probably the reason people are leaving. It's the biggest stressor and burden people are experiencing. I lost my train of thought.
It's also a burden
For the clients, yes, is what I wanted to say, to come in when people do walk in and they want to be seen, they want to tell their story. They don't want to get literally 10 pages of screenings and assessments and consents. And I mean, it is a packet. And so we moved it to our front end admin assistants, and then we have access clinicians that meet and do fee agreements, all those weight consents and waivers and informed of what they're participating. But I often wonder when they leave that appointment, even when they leave with another appointment in hand, was that a positive experience and were they able to tell their story? Because if we could put that paperwork aside and just listen, that's what people came into this field for. That's what we're experts in. But I think each of us are trying to manage it. And as much as the EHR is helpful, I actually think it's more pressure from a clinician's perspective. We absolutely hear that.
And I think the tension on both sides of that is one, they're always asking, well, how much of your time is spent on direct service? And we want to see the most of that. But it's so compliance heavy that you just have to hire admin staff. Like you said, if we're offloading administrative burden to other staff, they're not seeing people, they're doing paperwork. And so that's again, the tension on both sides saying limited administrative, costs. You don't want to see those too high, but it's required to meet the compliance state of the regulations, which is more prove it, saying show us you're doing the work, but that requires a whole army of people that aren't doing direct services. So
But also it leads to better job satisfaction for those actually providing clinical services, which is the mission, I think.
I just want to put in a plug because I see that one of your challenges is, and we've long known, reimbursement rates is a problem. And it's a problem that impacts everyone that lives in Vermont because it impacts access, right? And availability of care. It relates to the documentation problem and the administrative problem, right? Because I think a lot of, and I don't want to offend anyone, but I think a lot of our providers don't really know the true cost of delivering care, right? Because it's infinite, the amount of things like your electric bill, the amount of things that go into delivering one 15-minute service, a 30-minute service, right? And if you've worked with MTM, because Scott Lloyd will hammer this home. And I personally would love to invest in all of our DAs calculating that out. I think it's one of the most valuable investments we could make because then you can leverage that true number to negotiate what it truly takes you to deliver that care. And I think, equipping yourselves and us with an accurate number of what it takes is so priceless, right? And I think it also helps you assess whether the administrative burden is truly what is required. MTM has a service that they actually have narrowed down documentation requirements and, turned thousands of pages of CMS requirements and state regulatory and Joint Commission requirements into 200 pages instead of 1,000. So I'm glad you're working with MTM because they're the experts in that stuff. And I would be really happy to entertain requests like more work with them because it's invaluable to our system.
They were part of the right person, right place, right time, and matching the expertise with the work. And filling out forms can be done by a case manager. It can be done by somebody else. It doesn't have to be that master's licensed level clinician.
Right, and we have to make
Absolutely
sure
agree.
that the forms are still required because I know our federal and state requirements change frequently and sometimes the burden can be lessened.
Great information. And there's some great information coming up and I want to get to it. So.
Thank you. So we were just talking about what we should skip through. There's a lot here. There are opportunities. There's more information on our vacancy rates. I will just say that there's, as you all know, a lot of state and federal changes that we're all embarking on and involved in, which a lot of which is really exciting. CCBHC, for example, which I think really helps the state and all of us get to a more integrated, our vision of an integrated delivery system. It's also pretty taxing and nerve-wracking because of the unknowns around it, DS payment reform and conflict of interest, free case management, and how that impacts our CRT population. It's just a lot. So we can come back and talk about all those different components, but just to say that it is, I think, both an opportunity and a threat to be implementing all of this at the same time. We've talked a lot about the workforce barriers and challenges. I do want to take the opportunity to say thank you for the tuition assistance and loan repayment. It has been invaluable to the workers and to our staff at the agencies. We just started our second year of this round, and we are collecting robust data. We will have more of that available to you.
Remind us what the work requirement is for that. Is it 1 year to 1 year or?
6 months to 1 year, depends if it's either tuition assistance or loan forgiveness, and depending on which path you take.
Okay,
There's 6 months or 1 year.
okay.
Do we want to, we only have 10 minutes. We really wanted to talk about the CCBHC and the financial component. So I guess it's more up to you all about.
Yeah, I really wanted to hear about CCBHC. I finally got the acronym right. I struggle. This is
a hard one.
I have a mental brain block around this acronym.
Yes, yeah, I think a lot of people do. That's fair. So we have 2 agencies that are going through the certification process right now, Clara Martin Center and Rutland Mental Health. And then we have 4 more who will be going through it in a year or so, maybe a little less. Northeast Kingdom, HCRS, NCSS, and Howard. And then the remaining organizations will apply through. We are hopeful that all will become certified community behavioral health centers.
Can you really quickly explain what that is?
What a CCBHC is and how it differs from what we currently do. Yeah. So there are a number of core services, and Melanie and Christy, you can get to the detail of those. I'm going to talk about how the way I see it really differing from what we do now is an expansion. It's a formalization of co-occurring with substance use and mental health. It's increased coordination and integration with primary care. It's increased access, especially with veterans. And I think another piece is the requirement for a robust needs assessment. And I think that's what that's really showing is we've always known a lot of the needs in our communities, but this is even a deeper dive. And so getting a sense of some of the more marginalized populations and what their needs are and how we can afford to meet them where they're at as well. Part of, you were talking about cost-based reimbursement, part of what agencies have to do is fill out a cost report. And CFOs have been working quite a lot on that. And our hope had been that we could do sort of a template across the system to get at what you were exactly saying. What is the actual cost here and now, and what will it be with CCBHC? And we're still in the works on that. So that is a long process. It's extremely detailed, and it is not just a financial one. You need to get a lot of folks in your agencies involved in that, because you're looking at what is the appropriate staffing pattern, what is the appropriate pay, what is that based on? We look at Bureau of Labor Statistics, et cetera. So I think it's an exciting opportunity for Vermont, and it was started in large part at the federal level, right, to provide a bit more parity between FQHCs and community mental health centers, both in funding and in incentivizing working more closely together. And I think that is hopefully what it will result in.
I think the only thing I would add, Simone, is it also helped us develop our peers and hiring people with lived experience. And I've been so impressed by the effectiveness of peers and the experience that clients have had. And then mobile crisis was part of that before we got the grant as well. So having a 2-person response that went out into the community, we had started that through the CCBHC process. Christy, you've really been at the heart of this. effort for Clara Martin Center. I'm not sure if you have something to add as well.
Yeah, so I'm Christy Everett. I'm the Director of Operations at the Clara Martin Center. I think, we've been dealing the longest with CCBHC at the state level since we got our grant in 2021. And I think it's really looking at our system of care under the umbrella of CCBHC, and every piece of it will fit under that continuum in some way, other than like our residential services and some school-based services. But the real focus of the work has been trying to kind of, like what's been said, meet the needs of the community, identify what they are, and then bring services to bear and develop that. Really focused on sort of whole person care. What does someone need? It's not just mental health, it's not just substance. It could be assistance with primary care services and how that intersects their medical needs with their mental health needs. Making sure that we can help people receive those services, if not through us, that we can help them connect the services in the community. And how do we address those needs on a more global scale? I think it's been transformational in how we've been able to support staff that are doing this work. Working on the administrative burden, very thankful for the work with MDM. We do have some potential additional options that we are looking at with them as well. But as we address sort of the pay increase needs, we've also been able to support staff to get training in like evidence-based practices and identify like what needs are out there, what is our community saying, our trends that we have, and we put services in place around it. And I think I've said it before, there's no primary agency that has not been touched in a positive way by CCBHC. I think we've been really thankful to have the support of the VCP network, support of DMH and DSU to really do this collaboratively. So we might have a grant at Clara Martin Center, but we're working with the other agencies to share best practice, what we're learning through CCBHC, learning what MTM has shared with us on same day access, and how other people can sort of benefit from that knowledge as well. I think the biggest thing that we're working with right now as we go through certification is trying to help support our state agencies in their alignment efforts. We will go through certification. We also are going through designation at the same time. So those two processes are still going to happen, but the state is trying to sort of align those into one process. So we have one set of criteria, one manual to follow, one reporting mechanism, but it will serve different parts and pieces of that. So I think it's been a great collaboration with our state partners as well as we've explored this and tried to build it out. But when we look at sort of that administrative burden, some of it is larger than us. And how do we sort of help support that at state level to bring things into a better alignment?
And this is funded by a federal grant.
Currently, we're funded by a federal SAMHSA grant. We got our first grant in 2021. We got a second grant in 2022. Now, as the state was accepting demonstration, we're working with states through that, but our federal grant ends in September of 2026.
Okay, great.
We just have a few minutes and I would love to just touch upon CPI and I don't know, Heidi, whether you want to join in on this conversation. It's an important one and really quite striking when you look over the years. So do you want to come to that?
So I'm Steve Manili, the Chief Financial Officer at the Howard Center. Do this in 2 minutes. So there's 3 slides there, there's a lot of information. I won't give you all that information in 2 minutes. We're going to run through it really quick. So what you're looking at right here, the left column is our CPI since 2008. The second column over is the increase from DMH and Dale. Fourth column over is our inflationary increase from DSU. And the red columns, as you can see, the third and fifth column is our shortfall in comparison to CPI from those Medicaid increases. I would also put this in context that this is assuming that we were funded in 2008. And I think there could be some arguments made that we were maybe short in 2008 and it's just been compounded since then. I'm going to slide forward to the next slide. This is our days in cash on hand. You can see the green bars are the hospital system. The blue bars are the DA system. So you can see we had some cash come in COVID, and it was nice. It helped us get through that. That's all kind of gone away. We're basically back down to pre-COVID levels of cash. Would also say that 63 number is our system average, not the floor. There is some that I know we at Howard Center are in the twenties most times, and that too is not the floor. There's swings and we have to pay payroll, or if we don't quite get as much, or payments are held up, we get lower than 20, which is not where we want to be. I know there's a lot of news about the hospital fragility. You guys are very plugged into that. We are fragile as well. Just wanted to show that, make sure you understood that.
Can you give us an idea of what a healthy days on hand would be?
The state says 60, they want us to be at, we
90?
want to be closer to 100.
90.
90, okay,
Okay.
90, that's good, yeah, I'd like to be closer to 100, I would feel more comfortable. 3 months, would be more comfortable. Yeah, so if you want to go to the next slide, so this is our payer mixes, our system versus the hospital system. I just want you to really understand, we're gonna do as much as we can to impact that 7% slice. As Daisy knows, we've talked to, some of your constituents in Winooski. We're doing what we can on that 7%, but we need some help with that 90% as well. So just as you go into this legislative session, I guess that would be our ask, is to help us out. What we can do on that 90%.
I think that's the difference, that you're really gonna see is that the designated agencies don't have a place to cost shift, right? They aren't able to shift to the private payers, it's such a very, very small piece of that.
Okay, and then I think we're going to the next slide. We won't get into the details, but just to let you all know, Amy will be here to do this part. No, but to let you all know that we are asking for a rate increase this year, a 6.2% Medicaid rate increase. And we, our CFOs have worked diligently to really give, to have that be a strong number and to have it be based on a number of different factors, including what you see here. So the 4.8% salary increase based on US Bureau of Labor, average projected health insurance increase of 13.5, which is average. It is so much higher for some. An average projected increase of 6.2% for other fringe, and then the general liability, auto, others 6.5, and then all other operating projected to increase 3.3% based on the New England CPI. So this will be our ask, is our ask. And, I would say that this is to keep the lights on. And while we are investing in our crisis continuum, and while we are hoping to have an increased investment in prevention and early intervention and upstream services, especially given the impacts of closing of hospital beds and acuity within the community, this will be essential.
I have not seen the budget yet. Is this in the governor's recommend?
We have not seen it yet either.
Thank you.
Connor just said it's stuck. Yeah, you said something.
Daisy.
One, I just want to commend you for taking an incredibly underfunded and overworked system that's so critical to everyone in this state, and really bravely, Christy and Clara Martin jumping in and taking initiative with the CCBHC model. I just want to make sure everybody understands that model is a federal model. It was born out of the FQHC model, which, they analyzed all the successes of the FQHC system and said, how can we do even better? And that's what the CCBHC model is. And funding for the CCBHCs, although it is federal, it has over the last 4 years been increasing very steadily. And I know right now federal funding is really wacky, but the trajectory, even through the last administration, was pretty consistent. And I am just really thrilled that the whole system, it sounds like, has a really good understanding of the benefits of the model. What are the threats to our entire system adopting that model?
I think some of them are unknown, right? We don't know what we don't know about the new model. I worry about the cost. It is increase in services and moving to cost-based reimbursement. So what does that really look like and how do we fund that? I do think there are some of the outcomes and the data requirements are more medical than we, I think, typically would support, wrap our arms around. And so I think that shift will be a harder one. There is actually in some ways more data collection necessary. we are looking at how we can find some efficiencies across the network and in doing the data collection and the data analytics around that. I leave
I
it to.
think my concern is just the current state of the federal funding and the investment going forward. Up until the change in administration, I think all tea leaves were the federal government this was the road to go. Our experience clinically is it's the best, and from a community perspective, it's the route to go. I think the concern now is it feels like is the carpet going to be pulled out from under us, just in terms of the federal funding and investment to continue it and at what level. I also get concerned about the DEIB. That's been a big component of CCBHC to date, and just where our environment is related to that. And, it's part of our core strategic mission to support marginalized populations in all of our communities. So I worry about that angle as well, and what the impact that I hear may have in terms of our ability to accept things, but we'll figure it out. But that's as of today.
Yeah. And sorry, did you have a question?
I'm sorry. Leslie, did you have a question?
I do. I just need help understanding looking for support, your very last slide. Where you say 6.2% Medicaid rate, but it's a 5.2% increase overall. What's that difference?
So our expenses are going to be increasing by 5.2%, but as we pointed out in our other slide, Medicaid does not fund all our entire program. So in order to generate enough revenue to cover the 5.2% increase, we would need a 6.2% increase on Medicaid rates.
Okay, so that 5.2 is your increased expenses overall.
Yes.
Got it.
Yeah. And that is a concern for CCBHC too. The areas of the state that have more private insurers or client coming into your agency, we worry about how financially viable the CCBHC will be with that. And that's a deeper, longer conversation, but it is a concern because it's Medicaid funded. And so we do really need to be working more with our private insurers, Blue Cross and others, to get them to invest in the CCBHC model as well. And I know.
I think that in the interest of time, I think we're going to end, but thank you so much for coming in. And there is, I know, so much information. Frankly, we could spend hours and hours on this.
Thank you for having us, and
you.
reach out
Thank you.
if any questions. I mean, Amy's here too, obviously a lot, and but anytime you want us back to provide more information.
I think we're going to take a 15 or a 10-minute break. 10 minutes. So let's be back here at 10:45.